I want to close. I'm surrounded by busy clinicians who basically do GI cancer all day, every day. So we should be the world's experts in how to manage side effects. I'm going to pick on each of you a little bit. Johanna, how about hand-foot syndrome?
Hand-foot syndrome, so seen with capecitabine and now also seen with regorafenib. We saw that data, though, albeit in a different tumor type. This was sorafenib. For hepatocellular cancers, looking at urea-based creams, use TID to help decrease the grade as well as the incidence of hand-foot syndrome, so that's always a good thing. With the capecitabine, always tell them to get the lotion on if they can, and the men hate doing this, is put the gloves on at night as well as the socks on at night, keep things moist.
It's a Michael Jackson thing for us. We really have trouble with that. Axel, the world's expert in oxaloplatin neuropathy. What should we do there?
Stop it early.
Stop it.
And but actually, so one of the reasons actually why I like FOLFOX in the palliative setting as first-line treatment, it forces us to an induction maintenance therapy regimen. So the neurotoxicity is very limited if you really give only 8 cycles of FOLFOX, and that's my sweet spot. Actually, when I give lectures to our fellows, whatever, I say, in a palliative setting, purely palliative setting, where response is not the main issue but delaying tumor progression, I always stop oxaliplatin after 8 cycles. Yeah. And if this is a message that can be conveyed, including actually using a non-bolus 5-FU containing FOLFOX, which decreases neutropenia, you really don't need, and mouth sores, mucositis. Modified FOLFOX7 with 85 milligram oxaliplatin regimen, 8 cycles, patients really don't notice it. And they don't have alopecia. They have, if at all, the main side effect could be diarrhea and sometimes fatigue, but it's a very, very easy regimen of patients.
Heinz, I see tons of patients getting growth factors with our regimens. So, the concept of dose intensity in the metastatic setting, coming back for a hit of a growth factor, versus dose modification. There is some around irinotecan. There's some emerging data around dose intensity around irinotecan. So I can't be too sweeping, but what's your thought on the use of growth factors to treat myelosuppression versus dose reduction?
I barely use it. I do dose modification. And I think just the examples we talked with 5-FU, it's not only the dose alone, it's the administration schedule. And I think we have learned to do dose modification that we get by. I think sometimes it's also a little bit misleading because, clinical trials, we have to hold and dose modify for 1,200 neutrophils. I don't do that in private. No. So I think sometimes toxicity mislead about the toxicity profiles. It's not as bad. And I use usually dose modification in order to address in the low chances of great, really clinically meaningful toxicity and neutropenia. So I very rarely give it except neutropenic fevers, not as a prophylactic and dose identification.
I've saved the hardest for you, yet again, Henning. So, and I really want to know how to take care of this fatigue, asthenia. We're seeing more and more drugs that cause this chronic low-level fatigue. It's not just true in colorectal cancer, it's true in other diseases too. It's a clear side effect of many of our new oral smart drugs. You've got a lot of experience on this. Any good, and Germans are hardy stock who don't complain much, I have a feeling.
It's the beer.
It's changing. Well, asthenia is especially challenging because we have to separate it from the natural course of the disease. So is it a sign of the disease or is it a side effect of our drugs? And this is what I feel, especially in last line, very challenging. So we have first to make sure, is it the disease or the drug? Most of the time, it is the disease, yeah? And the drug is actually adding some more fatigue on that. So unless you check for hemoglobin levels and can correct those, this is one issue. But most of the time, this fatigue is not associated with anemia. Yeah? So I think it is really hard, and once we have to separate it from disease progression, we have to take a decision sometimes to take the patient off the drug. Yeah.
Are there going to be changes in dose, you think, some breaks and
I have patients, a couple of patients, who, although they responded to, let's say, regorafenib, they said, "Oh, the best decision I took was to get off the drug." Yeah, unfortunately, although it's so effective. But this is why I think there's a dose issue. So dose reductions probably can do that.
Henning, thanks very much. Johanna, Axel, Hines. You know I love doing this. I love being with you, and I learned so much, and I hope the gang out there learned a lot. I hope this was a useful period of time for you for our clinical advances in the management of colorectal cancer. Come back to this site for other cool stuff. Thanks, John Marshall.